Welcome all of you to this live program at Orthopedic Principles. Today, our guest of honor is Carlos Maia from Lisbon, Portugal. Carlos is a shoulder surgeon and head of shoulder unit at the Hospital Cuff Tejo in Lisbon, Portugal. Carlos completed residency at the Hospital Listal di Centrum and has been board certified at the European Board of Orthopedics and Trauma. He completed his PhD in bioengineering involving stem cells and regenerative medicine at the Instituto Superior Técnico Lisboa, Portugal. Now also holds a post-graduation in sports medicine by the Portuguese Society of Sports Medicine. He's been a member of the Portuguese Shoulder and Elbow Society for several years and currently serves as the president-elect for the Portuguese Shoulder and Elbow Society. So today it's my great honor to introduce you to Dr. Carlos Maia from Lisbon, Portugal. Over to you, Carlos.
Thank you, Tesh. It's a great honor to be here, and thank you again for the invitation. This is a very dense work that I'm going to present to you. So surgeon decision making is never easy. And if we look at the data, sometimes it gets more difficult because we can't see all the missing pieces. And what I'm trying to do with this presentation is not give you the answers, but give you some food for thought. Because, of course, some of these data, you cannot translate it directly into the clinical practice, but it should make you think if your decision-making is being the right one or not. So let's just start. We do need to plan for any tendon repair, and I'm going to be very specific about shoulder because this is my area of interest. We do have to respect some principles and treat those that need. And in order to get a stable and long-lasting repair, we basically need to be aware of two things. First is biology, and then on the technical aspects of surgery. Regarding biology, of course, we cannot control most of these variables. There are general and local variables, and these are things that we cannot control directly. So it's something that we have to deal with. Every patient is different, and we cannot choose the patients that enter through our door. What we can choose are the technical variables. So we can choose our approach. We can do an arthroscopic or an open. We can choose the material. We know that different material design equals different pull out of the sutures or the anchors from the bone. And we can choose the geometry of the repair. But is this the only thing that we can choose? So is this all that we do in the OR? And as I'm going to show you, probably not. We see a lot of other variables that have been scarcely or very few papers have discussed them. So they are the medial row mechanism. Actually, this is a term that has not been coined yet. We have only described the tied and the knotless repairs. But the medial row is more than knot tying. Sometimes we may think as the knot tying as making a medial row in a non-sliding fashion, because there are anchors that allow sliding of the sutures, and there are anchors that don't allow the sliding of sutures. And we always think as the knot tying as being the key factor when you're doing a tied medial row. But my challenge to you is to start thinking of that as a rigid medial row and not only as a tight medial row, because sometimes, as you'll see, it is the fact of non-sliding or sliding the medial row sutures that may have some interference in the biomechanical and the mechanical factors on the cuff. Of course, also the number of sutures passed and the type of sutures that you pass, are they sutures or tapes, may have some interference also. So this is what I was telling you about. So we do have the tied and the knotless repairs. We have to be aware, of course, of the number of sutures passed. And what we do understand is there's quite a lot of biomechanical data that describe that the higher the load to failure and the higher stiffness of the repair apparently brings better mechanical results. And that may be true, and it's probably true because that increases the pressure, the force, and the stress also at the tendon-bone interface. And those data, that clinical and mechanical data, have been regularly printed in papers in the literature. And regarding tapes and sutures, we have also seen some data that tapes have a higher resistance to pull out they reduce gap formation, they increase the load to failure, they increase stiffness, and they increase tendon contact pressure. And that was something that I had some doubts about it, because if you find that pressure is a relation between force and area, I was not able to understand how come tapes generate more pressure if the area of contact of a tape is higher than that of a suture. But I was very interested in understanding the mechanical influence of these choices, not only the type of surgery, the geometry of the repair, the type of material that we're using, the number of sutures passed, how do we pass them, if we use sutures or tapes. I was very interested in studying them. There was a biomechanical, and I believe that we all know this, that the most stable construct was the one that increased the load to failure, increased stiffness, and diminished gap formation. And the consensus was that the most stable one was a suture bridge pattern, meaning a tied medial row and a knotless, a lateral row with push lock anchors, with medial tied repairs, with a lot of sutures in the medial side and multiple passage points. But there was a question, and the question was if the stiffer was the better. Well, apparently there were some clinical outcomes that demonstrated that the less stiff repairs induced a higher retear rate than those that were stiffer, like this paper, for example, that demonstrated that single rows generated higher retear rates than double rows. Again, another systematic review from 2015 showing that double row and suture bridge technique yielded a lower retear rate than single row. The problem was that we were comparing not only the geometry, but also the number of suture passages and the type of medial row mechanism. And those were variables that were not described in the literature. This systematic review showed that we are not comparing exactly the same thing. This study also suggested what I was saying, that it is the number of sutures and the type of sutures that we pass in a rotator cuff that are the predictors of strength in the constructs. So there was a need, and there were some reports that started to show us that the strongest and the stiffest repair may be inducing a different type of retears. Okay, so we had a lower number of retears, but those that we had started to be more severe, which is the case of type 2 failures. And we'll see a little bit later what are these type 2 failures. And regardless of all the advances, we started to realize that the retear rates still remained high, and there was a retear pattern that occurred at the musculotendinous junction in this more robust repairs. And this is the type 2 retear. So type 1 is a retear, this was described by Cho, is a retear in which the tendon just detaches from the tendon, or it didn't heal, but there is a tendon that is floating in the shoulder and that we can reattach it. The type 2, the repair still remains at the footprint, but there's a retear that is medial to the previous repair site. And for that, it's more difficult to revise because we have less tendon to treat. So the question arose, which was, are the stiffer and stronger repairs better? And I asked myself, what happens if you have a very rigid construct or a fixation point that is supposed to elongate? And we know that it is supposed to elongate because the work by Jesse McCarron demonstrated that there's always a tendon retraction. It's normal in tendon repairs, even if the repair is okay. So if the tendon is supposed to elongate, if there is always some stretching of the tendon, if you have a very stiff repair, what happens, or eventually what happens, is a retear that is medial to the repair side. And this systematic review actually demonstrated. So look at this. This is in the left side, you see a type 1 retear. On the right side, you see a type 2 retear. And what this Bedier systematic review demonstrates is that single row repairs generate a lower type 2 retear than suture bridge, which are, like the biomechanical data supported, there are much more stiffer and robust repairs. So that's what happens. So if you have a very strong and very stiff repair, what happens is that the tear that we repaired initially keeps in its place, but the tendon medial to that, or the muscular-tendinous junction medial to that, just is able to, it may torn. Why does that happen? There are several explanations, several hypotheses. Suture tendon-induced necrosis by the tying of the knots, tension overload at the suture tendon interface, over-tensioning of the repair, over-medialization of suture patches, large holes by the instruments, or increased abrasion of the tendon. But those are all hypotheses. So for type 2 re-tears to occur, apparently a very high load to failure and stiff repair may not be the solution, but actually it may be the cause of these more severe tears. So apparently there's a missing piece. So we have very robust, very good material to treat tendons, but the tendons can't they can't deal with this stiffness that we are inducing them. So what is the missing piece? I really don't know. So I went back to basics. I went to try to find the golden cross between mechanics and biology. And I evaluated my own data. So I work at a clinic mainly with workers' compensation patients. And we did retrospective evaluation, clinical and imaging evaluation of our patients. And we had, between June 2017 and 21, we had 241 rotator cuff repairs. One group had a medial row with sliding tapes and double, which means individual passage, which means that every tape, every limb of the sutures was passed individually in the tendon. And then we had another group with a smaller number of patients that the medial row, the tapes were not sliding, so they were locked in the medial anchor. And also the passage point in the tendon was single, meaning that the limbs, two limbs from different anchors of the medial row passed together in the same hole, in a single hole in the tendon. So it was the same number of limbs, but just passed in smaller holes in the tendon. These were the inclusion criteria. And then we ended up with 118 patients to evaluate clinically and only 71 to evaluate the imaging. From the clinical point of view, there was no difference between the groups in terms of improvement. So both of them improved, and they didn't show any difference between both groups. But regarding re-tear rate, what we did understand is that the medial sliding tapes with individual passage of the sutures had a smaller re-tear rate than those patients that had a single passage, like two limbs in the same hole, and non-sliding medial row anchors. Curiously, the number of type 2 re-tears was the same. And this was one of the main motivations for my PhD thesis that mainly involved in evaluating the differences between tapes and sutures, the ratio of suture to tendon hole, and lateral row tension, which we also found to be a very important factor regarding the consequences at the tendon-bone interface. So these were the experimental tasks. So we used a simulated transosseous rotator cuff repair with different medial row mechanisms, and for that we evaluated the progressive loading pattern intraoperatively to see what happens during surgery at the tendon-bone interface. We also evaluated the different medial row suture passage patterns and different suture material, and we evaluated the repercussion at the tendon-bone interface, and also at another location, which we called the medial bearing row, which is the line that connects both medial anchors. And as you see, it's the region of the tendon that is most subjected to stress in the repair. And then we also evaluated the medial row mechanisms and the lateral row tension at that same tendon-bone interface and medial bearing row. So these were the reasons for this task, because there was not a concept of medial row mechanism. There was no data on the progressive contact force during the execution of a repair. Then there was no data on the medial bearing row force that was applied, and there was no data on the effect of suture to tendon hole ratio at the tendon-bone interface. And there was a lot of conflicting data, and the number of studies that used controlled lateral row tension, which we did, was very, very small. So we started by evaluating the progressive contact force at the tendon-bone interface during the execution of a repair. Our hypothesis was that different medial row mechanisms would generate different progressive contact forces at the assembly. So we use this type of models that I'm sure you are all aware. In this preliminary report, we didn't use lateral row tension control, but we did find, and we had a very small n at this paper. What we did find after doing the proper calibration and using a force resisting sensor was that the patients that had sliding wires and sliding tapes had a more progressive contact force during the execution of the repair than those that had non-sliding medial row tape. So this was what we found. When we put the first lateral anchor, if you use a sliding mechanism, there was an increase of force at the tendon-bone interface that is around 40% of the total force, a little bit less than that. But if we use a tied or a non-sliding mechanism, when we put the first lateral row anchor, the force that is applied on the tendon-bone interface is over 80% of the total amount of force. So this means that different pattern of medial row mechanisms generates different progressive loading patterns at the tendon-bone interface. This also implies that there is different stress in different anchors according to the medial row mechanism, and for that we should avoid placing the anchors that are most critical according to our own preference, because if I prefer to use non-sliding mechanism, medial row mechanisms, then I should be aware of the location of my first anchor. If I choose to use a sliding medial row mechanism, then I should be aware and not put the lateral row anchors, the second lateral row anchor, in a bone cyst like it happened on this case that eventually went to failure. Our second experimental part was to evaluate the mechanical effect at the tendon-bone interface, again, of a simulated rotator cuff repair with controlled lateral row tension using different types of sutures and medial row tendon passages. So this was published in the Journal of Experimental Orthopedics in 2020. And our hypothesis was that under the same mechanical conditions, tape would increase contact force, area, and pressure, because this was the data that was available at the time. And that double hole passage would increase the area. Double hole means single individual suture limb passage in the tendon. So per each hole, there is a suture limb passing. So again, we use the same model that we described earlier, but we use a different sensor. We use a TechScan 5051 sensor that has a lot of sensors per square meter, 62, and will give you some nice image of the force that is applied. And this was the assembly. Another thing that we did, which is not very seen often in the literature, is we controlled the lateral row tensions. These two cylinders, metal cylinders that we see on the right side at the blue arrow, those two cylinders are pulling at a controlled lateral row tension on the sutures that come from the medial row anchors. And we pulled them and controlled lateral row tension individually. We didn't control them like two suture limbs in the same tensioner, because if we do that, what happens is we will only have the value of the tension of the tautest suture and not of the one that is slacking. So this was we had to take care of that in order to diminish the number of biases in the results. So in this paper, we had 4 groups, with each one with a number of 5 trials. We had a tape, as you see on the bottom, a tape single passage. On the left side, we have a wire double passage. On the top side, we see a wire with single passage, and on the right side, you see a tape with double passage. And then we went to evaluate the contact pattern using the TechScan sensors with lateral controlled tension. And this is just an example of the image that we got. If you see on the right square on the top, you see a white line. That white line is exactly the medial bearing row, which is an area that we empirically knew that was being stressed, but we didn't know how much. And you're going to see how much stress does that area receives. So we evaluated the contact force, contact area, contact pressure, the value and location of the maximum force applied, and the force distribution pattern. What did we understand? Well, we understood that, in fact, regarding the force and pressure, it is the wires, not the tapes, that generate the highest amount of force and pressure at the tendon-bone interface. And this is against what was reported in the literature. There were some papers too, actually, that reported the opposite, but again, they didn't control lateral road tension. So for you to see, if you have the same lateral road tension applied in suture tapes or suture wires, wires will generate a higher contact force and a higher contact pressure. What about area of contact? Well, area of contact had no difference regarding tapes or sutures, but it did have an influence about the number of passage. So if you have a single passage or a double passage, it means if you have two sutures in the same hole, or just one suture per tendon hole, one suture per tendon hole will increase the contact area. And if you recall that the pressure is a relation between force and area, if you have a very high force and a very small area, then the pressure is very high. And that may be the problem. We don't know. This is just mechanical data, so food for thought. Again, if you use tapes, you'll have higher force and higher pressure, and the area will be the same. If you have wires, you have higher force and higher pressure, and the area will be the same as tapes. And if you have double passage, your area will increase while the pressure and force at the tendon-bone interface will be the same. Regarding peak force, because the last anchor applied, as you'll see on the paper, was the posterior lateral anchor, of course, the posterior lateral quadrant was the one that had the highest peak force. And there was no differences regarding, there was a difference regarding the wires and the single passage that did generate higher peak force than tapes and double passage. And what about the box pattern? What the left side graph shows you is the force along the box. So left means medial, right means lateral. I'm speaking about the left graph. And what we see is that it is at the medial bearing row, regardless of the type of repair that you do, that you have the highest amount of force of the repair. So I think that this shows that there is no surprise if you have a very, very, very stiff repair. It is at the medial bearing row that the repair will fail, because it's the highest point of stress concentration of the repair. And again, and this on the right graph, what we see is if you find the posterior is on the left and anterior is on the right, because the last anchor placed was on the posterior posterolateral position. The highest amount of force applied is on the posterior quadrants. But the main message is, the more medial you are on the repair, the highest amount of force you have on your repair. So in conclusion, if the stability of the assembly really relies on force and contact force and pressure, tapes generate less stable constructs while maintaining the same contact area as wires. Double passage increase the contact area, and contact force is higher at the medial bearing row, which is the highest concentration point. And it is tendentially higher if wires are used. So the question is this a risk factor for type 2 repairs? We don't know. The third and last part, we used the same mechanical model, but we used medial anchors with sliding tapes or non-sliding tapes, single hole again and double hole, and we increased the tension in lateral road to see what was the consequence of increasing this lateral road tension. This was also published this year in the Journal of Experimental Orthopedics, so you can check it out later. And these were our hypotheses. So regarding the medial anchor mechanism, we hypothesized that under the same mechanical conditions, the use of non-sliding medial row anchors increased contact force, area, and pressure, and it also increased the force applied in the medial bearing row. Regarding the type of medial passage, we hypothesized that double passage would increase the contact area without increasing contact force or pressure, as we had seen, and that single passage would increase medial bearing row contact force. And regarding the lateral row tension effect, we hypothesized that regardless of the construct use, higher lateral row tension would increase the contact force area and pressure at the tendon-bone interface, and it would also increase the medial bearing row contact force. So again, we use the same N, so three groups of 5 trials. One of the groups, which was double passage, we used tape with double passage, was used to compare the medial row passage and the medial row mechanism. We evaluated again in a box the same parameters that we evaluated before, and these are the results. So regarding the medial row mechanism, the force and pressure evaluated that there was a tendency that non-sliding anchors would increase the force and the pressure when compared to the sliding anchors. Regarding the area, there was apparently no difference, and regarding the medial bearing row force and peak force, again, it seemed to be that the non-sliding anchors increased there was a tendency for increase in these values. Regarding the medial passage, which was something that we had already evaluated in the previous paper, but done on these conditions with different lateral row tensions, what we did understand is that at low lateral row tension values, there was a tendency for double passage to have higher values of force and pressure. But at higher tension, which we don't control usually in surgery, but sometimes they're really high, we pull a lot on the lateral row anchors, that single passage increases or generates higher force and higher pressure than double passage. Regarding medial bearing row force and peak force, the results were the same. So at low tension, double passage generates apparently slightly higher values than single passage, but at higher tension values, it is the single passage that induces most stress at the medial bearing row area and generates higher peak force. Regarding the area, apparently there was a slight increase in area like we had seen before regarding double passage when compared to single passage. What about lateral tension effect? What did we find? Well, we did find that regardless of the type of repair, all parameters increased when a higher lateral row tension was used. So in conclusion, medial row sliding mechanisms tend to generate lower values of all parameters. Double hole suture passes, meaning passing the sutures individually in the tendon, increase contact area and lower medial bearing row force and peak pressure, especially if higher values of lateral row tensions are used. Higher medial bearing row force in the single passage is the norm, meaning that there is more force per suture hole, which may create an imbalance in stress distribution in a very critical area of the medial bearing row. And if the highest lateral row tension you use, the more force, the more pressure, the more area you will have on your tendon-bone interface. And those will increase in a significant manner, but especially medial bearing row force, which again is the most sensitive of all parameters in all groups. So bear this in mind. Very high lateral row tension means that you will be applying very high force in the medial bearing row, which is the area that is subjected to the highest amount of stress in your repair. And the most tolerant geometry to lateral row tension increase was the non-sliding double passage group, and the most susceptible was the sliding double passage group for most parameters. So the key messages of all this entire work is that different medial row mechanisms generate different patterns of progressive loading. If you use knotless constructs, be aware that sliding medial row mechanisms tend to generate lower force area and contact pressure and medial bearing row force, that the medial bearing row is the most stretched region of the repair, and the higher lateral row tension you use, the higher value of force, pressure, and area will you have, and also medial bearing row force will you have on your tendon to bone interface. If you use knotless sliding constructs, tapes generate less contact force and pressure than wires, and double passage also generates higher contact area. And if you use medially locked constructs, double passage also generate higher contact area, But if higher lateral row tension is used, lower contact pressure, medial bearing row force, and significant lower peak pressure are obtained if you compare the double hole to single hole passage. There are, of course, some strengths and limitations. So this was a reproducible work done on a mechanical setting. You cannot translate it to the clinical setting immediately. But again, as I said, this is some food for thought. You can think about this and use it at your own discretion for your clinical practice. Again, Hitesh, thank you so much for this honor. Sorry for the dense work and for all the graphs. But again, as I said, sometimes we need to think about what we're doing instead of just keep doing the same things that we have done in the past years just because we're used to it. Thank you so much.
Thank you, Carlos, for this detailed presentation. Carlos, you can stop sharing.
Okay.
Thank you, Carlos, for this detailed presentation, and thanks for sharing your research thesis. I mean, that also helped you in getting your PhD. Carlos, a few questions. I mean, it's a lot of, like you said, there are a lot of graphs and stuff. I mean, from what I understood, a little bit of stuff, I can recall, I can really correlate with some of the trauma stuff. For example, sliding wires were better. In a locking plate situation, for example, in trauma, if it is a too stiff an implant, it fails, right?
Yes, it's a very stiff.
Yeah, so I could easily relate it to the trauma, I mean, fracture union situation as well, because when you said sliding wires were better, means that allows for some movement, and again, it doesn't cause a re-tear, isn't it?
Yeah, we don't know that. Apparently, there's some the Bedier meta-analysis systematic review seems to shed some light on this. But again, the problem is that we are comparing apples and oranges in most meta-analysis and also systematic reviews. It's very hard to have the papers to go to such a depth regarding the variables. So they usually state, oh, this was a double row repair or just a transosseous equivalent. But as you see, you can have transosseous equivalent with tying knots, tying with sutures, with tapes, with single passage or double passage. So there are a lot of variables that most papers don't describe. So apparently, there is an increased risk for the use of non-sliding medial row mechanisms when compared to sliding. And my work with them, what seems to demonstrate is that the hypothesis for the medial bearing row being excessively stressed by not only the non-sliding, but also by the fact that you have just one hole per two or sometimes even three suture wires, that can cause a lot of stress on that region and create sort of like a dotting of the tendon that doesn't allow it to elongate and it just tears apart. I mean, we are not, there's no doubt that these more robust and stiff repairs diminished the re-tear rate, but we have got to a tipping point in which we cannot improve this only with mechanical improvement. We need to improve the re-tear rates now, again, thinking about biology. So it's this balance between biology and mechanics that we are still trying to figure out which one is best. There's also another important data that I want to really stress out, which is the lateral row tension. As you saw, I mean, if I had to say just one thing about this work, I would say just look at lateral row tension that you're putting in your repair, because that is the main driver of contact force, contact pressure, and medial bearing row force, regardless of what you're doing. So be aware if you're not overstretching and over-tensioning your repair. And actually, I think it was Buddy Savoy that said in his book or in a paper, I'm not recall, that all rotator cuff tears are repairable, but not all of them should be repaired. And he was speaking about the tension that you have to give to bring the tendon back to its footprint. So this is just, like I said, food for thought. I cannot say that clinically this will be very relevant, but try to think about this the next time you're doing a cuff repair. You may find some reason why a cuff failed and the other one healed, for sure.
And Carlos, how have you adapted this work into your clinical practice? For example, do you do single row, double row, suture bridge?
Yeah.
What are things you do? You do transosseous equivalent?
I do the transosseous equivalent. I usually transosseous equivalent with double passage, so tendon passed individually, and I use medial sliding. I already used, in fact, I started my practice with notch tying, a tied suture bridge. And then I passed to a knotless. I always use tapes because, again, there's another thing that we didn't discuss on the paper, which is the friction of the tape in the medial row mechanism, which is higher than the suture wire, and that friction sort of like buffers the amount of force that your lateral row tension induces on the cuff, because some of the force is dissipated in the friction mechanism. So I don't know if this is very important or not. What I do know is that transosseous equivalents generate a reduction in perfusion in the tendon. There's some animal studies that show that. And what we do need to find out is how much is too much. That's a very big challenge because, you know, every patient is different. We have patients that have very good quality tendons, other patients that have very thin tendons. If you have a patient that is a smoker or has hypertension, the number and the quality of the microcirculation will be worse, of course. So there's a lot of variables to be aware. But for sure, I think the integration between biology and mechanics will be the next phase of lowering the retear rate in rotator cuff tears.
And also, when you use the transosseous equivalent, you look at lesser carbon footprint, isn't it?
I'm sorry?
When you use a transosseous equivalent, we are reducing the number of disposable items. We reduce the wastage, and we are more in favor of a green surgery, isn't it, when you use the transosseous equivalent?
Yeah, I mean, if you use the transosseous, purely transosseous, you're surely reducing the number of implants. If you're using a transosseous equivalent with 4 anchors, you're actually increasing it. There's some devices that allow us to do the transosseous, direct transosseous repair arthroscopically. The problem with that is that some patients that have very poor bone, my work was not on that, but I have read on it. The problem is that sometimes we have an effect of cheese wiring of the sutures, and then again, tapes are probably better because they spread the force and the pressure in a larger area. So the risk of cheese wiring, I mean, cutting through the bone, is lower. Of course, tapes sometimes, and I've seen that in my work, and I've described it also. Sometimes tapes can behave like wires if they are like if you just twist it, they will become cylinders. So again, correct use of material is fundamental also to have the results that we want to achieve. So treat tapes as tapes and not turn them into wires.
Thank you, Carlos. Carlos, I think that's all the questions that we have for the session. Thank you for this fantastic presentation, and congratulations for being elected as the president of the Portuguese Shoulder and Elbow Society.
Thank you so much, Hitesh. Thank you for having me here. Really honored. Thank you.